Welcome everyone. Let's talk about some ophthalmological emergencies. Ocular injuries can be the result of accidents in the home, in the work, sport-related injuries, could be due to road traffic accidents or assaults. So the globe injury and periocular region can occur following major trauma sometime. If there is major trauma, you have to do primary survey, and in the primary survey, resuscitate the patient with oxygen fluid, things like that. And then after that, in the secondary survey, you have to ensure appropriate assessment and management of ocular injuries. The mechanism of injury also should be asked because it might be a blunt trauma, a penetrating trauma, a chemical one. This can involve lidus, globe, orbital wall, and adjacent structures such as brain and sinuses. Most of the junior house officers and many of the frontline accident and emergency doctors will have little formal ophthalmic training, and so it's useful to have a robust assessment point for them. So the assessment of ophthalmic trauma simply starts with an inspection. You have to inspect also the periauricular region in order to look if there is any obvious globe rupture, if there is displacement, or if there is bruising, lid laceration. But then after that, you have to do a systemic way. Best one is by ABCDEF of ophthalmology. So by doing this ABCDEF, it objectively assesses the ocular function and determines whether you need ophthalmological referral or not. The first one, ABCDEF, is A. A, you have to do visual acuity. The visual acuity is the most crucial, and most of the time it is neglected and omitted by treating physicians. If the patient is conscious and cooperative, you may and have this chart, it's better to do this. If not, just simply cover one eye and ask them how many fingers are there, can you see it clearly. So this is just a simple baseline distant visual acuity which can be recorded. Then on the B, you have to shine a light into the eye, which is normally leading to constriction, and the other eye is also will be constricting. This is called contralateral eye, but sometimes there is a problem in the optic nerve which leads to rapid afferent pupillary defect, also called rapid relative afferent pupillary defect. So if there is a problem in the optic nerve, or sometime even in the retina itself, normally if there is no light reflex, it is just a dilated one. Normal response with the light would be constriction, direct and indirect. But if there is dilatation instead of constriction, it means it is rapid, so you have to search for the cause and call the ophthalmology most probably. With that, you have also to look at if there is any evidence of globe rupture. So you see these abnormalities. You can see blood at the anterior chamber. This is called hyphemia. You can see corneal ulcers. This is the surrounding of the ulcer. So you can look at this with the B, with the bright light reflex. At C, you have to look for the cornea and conjunctiva. Use the same bright light as in B, but look for the normal corneal reflexes. You have to examine the corneal reflexes. Also to look for the intraocular content. Sometimes you can also see if there is a subconjunctival hemorrhage, which may raise the possibility of penetrating injury. It is useful to stain the eye with the cornea with a fluorescein in order to accentuate any corneal trauma. So this is subconjunctival hemorrhage. This is very common after trauma. You have to think about penetrating injury as well in such cases. Sometimes subconjunctival hemorrhage happens without trauma. This is simple, usually does not need treatment. Hyphemia is collection of the blood in the anterior chamber. It has different degrees. It is best for the patient to sit down in order for the blood to stagnate downward. And then you call the ophthalmologist. Disc examination should be done by the direct ophthalmoscope. Most of the time it's not available, and even if it's available, many doctors cannot master the ophthalmology, the ophthalmoscope examination. Anyhow, if you have such a ability, examine the optic disc. So you have to examine the optic disc and also the macular region in order to see if there is abnormality. It is wise also to examine the arteries for any dilatation and look for other signs which will come through that. Sometimes vitreous hemorrhage can be there. The inability to see the disc very well may be suggesting anterior or posterior segment injury, such as vitreous hemorrhage. Then after D, you have to examine the eye movements. So ask the patient to move the eye in order to examine for the cranial nerve, and also if there is entrapment of the muscle. For example, if there is an injury in the inferior orbital wall, the eye cannot move upward due to entrapment of inferior rectus muscle um, that prevents the eye to go upward. The visual field, lastly, is the F, the visual field examination. So you sit in front of a patient in a distance of 1 meter and bring something and tell the patient to look at you, and then move the object upward, downward, then on that side upward and downward, and make an edge in order to see if the visual function is good or not. So to summarize this: A, visual acuity; B, bright light reflex; C, cornea conjunctiva; D, disc examination; I, eye movements; F, fluorescent staining. It is safe to say that a patient with normal visual acuity, no relative afferent pupillary defect, normal corneal reflex, normal disc examination, and full eye movements and full visual field is unlikely to have significant ophthalmic injury. If you go by this ABCDE and the patient have no abnormality, you don't need to call the ophthalmology immediately, and even doesn't need referral actually. Coming to some of the eye problems and problems surrounding the eye. So with the inspection, you can see if there is an injury on that area, which needs ophthalmology to come and see the patient. This is maybe plastic surgery and needing plastic surgery. This wound needs absolutely needs ophthalmology, because it might involve the lacrimal duct and can have complications later on. Sometimes patients come with simple things like redness of the eye, and it might be viral, it might be bacterial. It is different. It is difficult to differentiate between them. So usually the bacterial one have sticky eye, have that mucopurulent discharge. That one is usually associated, the viral one usually associated with a flu-like illness before that, leading to conjunctivitis, viral conjunctivitis. Again, as we said, it is difficult to differentiate between them, but mostly in bacterial one there is mucopurulent discharge, while viral one have a watery discharge. Could be unilateral, could be bilateral, but anyhow, it can be contagious. So ask the patient, if they touch one eye, don't touch the other eye by the same hand, or wash their hands before that. Mostly you give antibiotic for these cases. So what is available in the hospitals are chloramphenicol, the chloramphenicol eye drops, eye ointment. Usually eye ointments used for night use, and we have also tetracycline. We have more tetracycline eye ointment are there, and can be used 4 times or 6 times daily in the initially. And also we have fusidine eye ointment, which can be used 2 to 3 times daily. So there are other commercial and also other antibiotics that can be used. Some ophthalmic doctors use steroid or use combination of a antibiotic and a steroid. So let that for the ophthalmology to be done. Subconjunctival hemorrhage. Anyhow, for the viral conjunctivitis and bacterial conjunctivitis, doesn't need to call an ophthalmology doctor as an on-call. You have to refer them later on. Subconjunctival hemorrhage. The subconjunctival hemorrhage is very common. Sometimes it might be due to heavy weightlifting or maybe due to a strong cough. Most of the time the patient doesn't feel that, and the family tells him that your eyes become red. This has different severity and degree, but does not need treatment. And it will resolve by itself within 1 to 2 weeks. Sometimes we use a weak steroid drop like FML eye drop. Can be used 3 times daily. It may lead to rapid improvement of the eye. Foreign bodies are also commonly presented to emergency department. Sometimes it's easy to make it out, but sometimes it is sticky to the cornea. If you do a fluorescent testing, it can accentuate the problem. We usually use a needle, most probably a small needle like a insulin needle, and we use the bevel of the needle. This is the bevel of the needle. Tangentially we use it not in 90 degree, I mean in the same angle with the eye we do it. So just look at this
lab examination, and now here I have removed the rust and flipped it over the corneal foreign body. You can see that rust, and now with the help of a 1 cc hypodermic sterile needle I will remove it from its place. Now look at this large foreign body which was still impacted despite someone tried to remove it. So you should always remove the central foreign body along with the corneal rest. Thank you very much.
Many times foreign bodies can be there in the upper eyelid, so if you invert the eye upward, upper eyelid upward, you can see the foreign body most of the time. So these foreign bodies can cause these lesions in the eye. You have to be careful. Coming to the chemical injuries, the chemical injury is the top emergency. The first thing that you do is you have to wash the eye. So the chemical injury can be acid or can be alkaline. Which one is more risky? Both of them, but alkaline is more risky because it can cause liquefactive necrosis. So it penetrates deep in the eye. The acid may cause coagulative necrosis. It will form a layer and cannot penetrate further, but the alkaline one is more dangerous. So you have to irrigate the eye thoroughly. Before irrigation of the eye, you have to instill xylocaine or anesthesia eye drop, and then wash it with the irrigation with a normal saline or with distilled water. But you have to use a lot of fluid in order to wash the eye until the pH of the eye become normal. So there are sticks to do the pH measurement of the eye, to do the follow-up.
Lie the patient down or get them to lean back on a seat. Tilt the head to the side of the affected eye. Place a towel and bowl to soak up fluid. Put local anaesthetic drops into the eye. Remove any contact lenses. Use your fingers to open the eye. Pour fluid from a close distance using a jug or giving set. You can also keep the eyes open with a speculum and use a large syringe to irrigate. Ask the patient to look in different directions. Make sure you irrigate the lower fornix and evert the upper lid to wash away any foreign bodies. If foreign bodies remain, then use a cotton bud to remove until they're all gone. Continue this for at least 15 to 30 minutes. If litmus paper is available, then stop when the pH is neutral. After irrigation, examine the eye closely. You can use the anterior segment loop of the arc light for this. Look for signs of a serious injury, such as blanched blood vessels, a hazy cornea, and, after addition of fluorescein and examining with the blue light of the arc light, corneal epithelial loss. If any of these signs are present,
the eye should be washed for a long time during a chemical eye injury for about 15 to 30 minutes in order to normalize the pH. Okay, another important subject is acute angle closure glaucoma. Usually these patients have previous history of acute angle closure glaucoma. What is the pathophysiology? It is, you have anterior and posterior chamber. In the anterior chamber, we have something called ciliary body. The ciliary body produces the aqueous humor. This aqueous humor goes through the iris and then goes to that area. There is an angle trabecular meshwork which is called angle of Schlemann. So this angle is between iris and the cornea. So there is an angle usually. This trabecular meshwork lets that aqueous water or humor goes to the posterior chamber. And then it will be going to CSF. But sometimes this angle, due to some diseases like myopia, will be narrowed. So when there is narrowing, the fluid will not be going there, and there will be increased intraocular pressure. So increased pressure there, increased pressure in the anterior chamber leads to these findings. The patient will be having history of blurred vision and feeling halos around the eye. There is headache. Sometimes, if you are not aware, you may regard this as a simple headache, as a migraine or something, but usually you have to examine. There is usually involvement of one eye. There is eye pain. There is also abdominal pain, nausea, vomiting, probably due to pressure on the vagus nerve, decreased visual acuity. As on examination, there is hazy edematous cornea, there is circumcorneal erythema, so there will be erythema around the eye. There is also raised intraocular pressure if you examine. If you look at the cornea, it is semi-dilated, not reacting well to light. And if you touch the globe from behind with your index and thumb, you have to press that globe. It feels like a filled ball with an air. Compared to the other side, you feel that the resistance and pressure is more in that side. So you can say this is acute angle closure glaucoma. As we said, there is usually history of the glaucoma. What is the treatment? Acetazolamide can be helpful. The usual dose is 500 milligram IV, followed by 500 milligram orally. If IV not available, you just go ahead and start with the tabs. It reduces the aqueous humor production. The second one is timolol. The timolol eye drop is a beta blocker, so you can it will reduce the aqueous humor production. So this one uses 3 times daily. This one also uses 3 times daily. We have also another drop called pilocarpine. The pilocarpine 2% can be used eye drop, applied every 15 minutes. After that, after initial 1 hour, you can use it every hour until it will cause constriction of the pupil and opening the angle. Mannitol is very important. Usually, ophthalmic doctors send the patients to give them mannitol. The mannitol we usually use 300 to 400 ml. We use it over 45 to 60 minutes. It will cause osmotic diuresis, which it reduces the intraocular pressure. Analgesia best if you use morphine. If the patient have severe pain, you use morphine. Sometimes you use antiemetic like metoclopramide or placil ampoule. Urgently do an ophthalmology referral if the patient not improved. Definitive treatment is surgery. There are different types of surgery, laser or surgical iridectomy. We have hyphemia, which is usually due to blunt trauma. There is collection of blood in the anterior chamber. It has different degrees. Sometimes it involves all the eye. You have to call the ophthalmologist and make the patient in sitting position and give them painkiller. Corneal wounds can be happening usually due to penetrating trauma. So in such patients, you have to give IV antibiotic, broad spectrum IV antibiotic, and also give anti-tetanus as appropriate, and give them analgesia and admit the patient, do complete blood count, blood group and RH, and do the virology, prepare the patient for surgery. Periorbital cellulitis and orbital cellulitis. So this is periorbital cellulitis, in which it involves any structure in front of the septum of the eye. There is superior and inferior septum, which prevents the infection to go into the globe. But if there is just infection of the eye, of the skin surrounding, this is called periorbital cellulitis. You just give oral antibiotic. So this is orbital cellulitis, in which there is collection of pus in the eye and decreased visual acuity and increasing in the intraocular pressure. So can we differentiate between preseptal, it means periorbital and orbital cellulitis? Yes. The pain is there for both of them, fever, both of them, but the edema and warmth and tenderness usually more common with the orbital cellulitis. There is also conjunctival chemosis in orbital cellulitis. So this is chemosis. There might be proptosis. The eye goes forward because of increased pressure here. There might be the patient have restricted eye movement and pain with the movement, so there will be ophthalmoplegia in orbital cellulitis. The vision will be decreased because of increased pressure on the optic nerve. There is afferent pupillary defect. There is also optic nerve head swelling can be detected by ophthalmoscope. So sometimes there is collection of pus in these cases, so urgent surgery and intervention is needed. Coming to sudden visual loss. Sudden visual loss can be painful, can be painless. So it can be painful or painless. The differential diagnosis of painless visual loss is central retinal artery occlusion, central retinal vein occlusion. I will show you two ophthalmoscope views to look at it. And retinal detachment, the patient feels that there is a curtain coming down. Painful visual loss, we have optic neuritis. The optic neuritis have a lot of differential diagnosis in young age. It might be due to multiple sclerosis. Temporal arteritis, this is usually happening in elderly people over 55 years old with high ESR, and they have some rheumatological diseases. So temporal artery biopsy should be taken, and you have to give high dose steroid. Glaucoma, we talked about it. The patient is having eye pain, vomiting, and also decreased visual acuity, redness, increased pressure. Migraine, some people have a migraine and they have pain in their eye. So this is not very common, but you have to suspect from the history of unilateral throbbing headache, which is associated with phonophobia and photophobia. The retinal detachment sometimes happens. So this is the retina. It detaches from the surrounding area. There will be a tear. It usually happens in elderly, diabetic patient, myopes, or following trauma. There is flashing lights and increasing floaters, and the patient then feels that there is a curtain develops which comes across their vision, and the patient cannot see after that. So as if there is a curtain coming down. There is loss of red reflexes. Visual acuity may be reduced. The patient should be urgently sent for surgery, for ophthalmic surgery to be decided on. Central retinal artery occlusion on ophthalmoscope, you can see cherry red spot, and the retina will be pale in color because the arteries are occluded. There are some emergency points or treatments you can do. I will show you after this slide. We have also central retinal venous occlusion. The eyes will be red in color. There is cotton wool. Sometimes there is like stormy stand there on the ophthalmoscope examination. If you suspect central retinal artery occlusion, you have to do rebreathing the patient with their breathing. This is called rebreathing the CO2 in order to vasodilate the retinal artery, because CO2 is a vasodilator. Timolol eye drops can be used to reduce intraocular pressure. Acetazolamide, massaging the globe. If you massage the globe, you may dislodge the embolus in the retinal artery and improve the condition. Sublingual GTN, glyceryl trinitrate, in order to vasodilate the central retinal artery. Sometimes thrombolysis might be used, but there is no much studies for it, so usually we don't use this thrombolysis. Hyperbaric oxygen, and they are also under studies, so most probably sublingual GTN, massaging the eye, also this treatment is. And thank you.